What is BRCA? BRCA. Well, it is incredibly important when we're talking about breast cancer, also important when we're talking about ovarian cancer, but it's not just females that have to worry about this, also males. So an increased risk of male breast cancer, prostate cancer, and a whole host of other cancers in both genders. So today, whether you're a medical student or a resident or just somebody curious about BRCA genes, why this is important, we're going to get to it all today. We're going to do it right now at Citizen Surgeon. Today, we're going to take a deep dive into BRCA, or the BRCA gene. Now, what is BRCA? When we look at BRCA, this stands for breast cancer gene, and there are two types of BRCA, BRCA1 and BRCA2. Now, when you look into the literature, you may find that there is P or LP versions of BRCA, and what that means is that just means pathological or likely pathological. So if you see P/LP BRCA1 or P/LP BRCA2, that just means the pathologic variant of the gene. Now, why do we need to talk about BRCA and understand BRCA? Well, this gene in particular, if this is in yourself or a family member or one of your patients, they have a much higher likelihood of getting a cancer. Okay, so that's why we need to understand this. Now let's go a little deeper into what BRCA is. So like I said, there's BRCA1 and BRCA2. Now BRCA1 is located on chromosome 17, and this is involved normally in the repair of DNA damage. Now, the process of DNA repair is through homologous recombination, and we're going to talk about that in a second. BRCA2 is normally found on chromosome 13, and this also fixes errors in DNA replication. Now, we often see in cancer that genes that are responsible for DNA repair, when they go awry, we get cancers, and this is especially true in BRCA1 and BRCA2. Now, what is homologous recombination? So when we have a double-stranded DNA break, what we find is through this process, a homologous template, either a sister chromatid or a homologous chromosome, is used as a template to repair and get an exact correct copy of the DNA. So that is homologous recombination. Now, it's more complicated than that. I'll put a link in the description below if you really want to dive deep in what that is. But I always think it's important to know for these cancerous genes where we're talking about KRAS, or talking about P53, or today talking about BRCA1 and BRCA2, what do those genes do normally? And then that helps me remember what they do pathologically. So in this case, if we have mutations in BRCA1 and BRCA2, they're not functioning properly, we're not going to get this DNA repair mechanism that is normally functioning. Now, when we have a BRCA mutation, that can be passed along from generation to generation. And how do we look at this? Well, first, it's important to know that this is an autosomal dominant transmission between generations. If we go back and we look at Gregor Mendel and those charts for autosomal dominant transmission, and we look at single genes, we can set this up as a quadrant. So take a look at this. So if we have a carrier that has two mutated genes, let's call those capital A and capital A, and they produce an offspring with somebody who has normal genes, well, 100% of those offspring are going to be affected. If we look at the next one, well, let's say we have two heterozygotes. If we have two heterozygotes, then we're going to get 25% of the offspring are going to have both mutated genes. 50% of the offspring are going to be heterozygous. They're going to have one dominant mutated gene, and 25% are not going to be affected. So in this case, two heterozygotes producing an offspring that both have the BRCA1 or BRCA2 are going to be 75% affected. And then when we look down, we say, well, how about if we just have one heterozygote produces offspring with somebody that does not have a mutation, then 50% of those offspring will be affected. So you can see the autosomal dominant transmission of BRCA and why this can happen from generation to generation. Now, which ethnicities or which populations are more affected? Now, if we look at the incidence in Caucasians, we see that is 1 in 400. All right, but other ethnicities and other populations have much higher or even lower incidence. So let's look at this. So first, these are the populations that have a higher incidence. Well, why does this happen? Well, the two things to think about are founder effects and population bottlenecks. So if we have an isolated population and an isolated gene pool, we'll see that they have a higher incidence of BRCA mutations. So the Ashkenazi Jewish population, that incidence of BRCA mutations is as high as 1 in 40 individuals. The Icelandic population, the incidence is increased to 1 in 166, and also increased in African Americans, French Canadians, and Hispanics. We find that there is a lower incidence of BRCA mutations in Asians, Middle Eastern populations, as well as Native Americans. And so what is the cancer risk? And we're not just talking about breast cancer, we're talking about overall cancer, because when you have a mutation in a DNA repair mechanism, there are some cancers that are going to be more common, but there are a lot of cancers that are an increased risk. And so what are those? Well, if we look at females, we see that the two most common cancers with BRCA mutations are breast and ovarian. And I broke this down into BRCA1 and BRCA2 mutations. So for BRCA1 mutations, we see that the overall, the cumulative lifetime cancer risk is 72% for breast and 44% for ovarian. When we look at BRCA2, we see that there's a 69% risk of breast cancer and a 17% risk of ovarian. Now remember, it's not just limited to breast and ovarian cancer. We're going to talk about some other cancers that are at increased risk, so make sure to stick around for that. But let's look at males and male breast cancer. So what is the risk of male breast cancer in somebody with a BRCA mutation? Well, you can see here that normally for those that are unaffected, the lifetime cancer risk for males in breast cancer is 0.1%. And that goes up significantly if we have a BRCA2 or even a BRCA1 mutation. So the highest risk is for BRCA2 mutations, and that risk is 1.8 to 7.1% over a lifetime. And for BRCA1, it's 0.2 to 1.2. So still up to a 10 times risk with BRCA1 mutations. And we're going to talk about surveillance and what we can do to lower the risk of getting a breast cancer a little bit further on in the video. We're going to do that not only for females, but also for males, and we're going to do it not just for breast cancer, but also for ovarian and a couple of others. Now, one thing we didn't talk about was age. So BRCA mutations lead to increased incidence of cancer in early adulthood. And for BRCA1, that increases up to the ages of 30 to 40, and for BRCA2, that increases in ages up to about 40 to 50 compared to the normal population. Well, how about males? What's the average age that somebody with a BRCA mutation gets cancer? Well, that age is at 64 years of age. So usually in that 7th decade of life. So as we talked about, it's not just breast cancer or not just ovarian cancer, but there are other cancers. So what other ones do we have to look at? Well, let's look at females specifically. Well, in females, we see that there's an increased incidence of fallopian tube carcinoma, ovarian carcinoma, endometrial carcinoma, and uterine papillary serous carcinoma. When we look at males, as I said previously, there is an increased incidence of prostate cancer in BRCA mutations. And you can see here that in non-carriers, a cumulative lifetime risk would be 7 to 26%. But in somebody with a BRCA2 mutation, there is up to a 61% risk of prostate cancer. Now, the other thing to talk about is that there is decreased survival in BRCA1 and 2 carriers who end up getting prostate cancer. So that part is really important. Well, what are some other cancers we need to worry about in both males and females? Well, check this out. We can see that both males and females have an increased risk of pancreatic cancer, an increased risk of colorectal cancer, an increased risk of melanoma, biliary tract cancers, and stomach cancers. And this is with the PLP, or the pathologic or likely pathologic variants of BRCA1 and BRCA2. Now, what have we been leading up to? We've been leading up to, well, what do we do about it? All right, so how do we do risk management in people that have BRCA1 and BRCA2 mutations? So the first thing is, this is complex, okay, very complex. I'm gonna put some links in the description below so you can get some good understanding and get some good literature that is very, very helpful. But if you're a patient out there, or you're a family member of a patient, it's really important that you talk to your doctor about this and that you get referred to a specialist, either an oncologist or a geneticist, that can plan your most effective strategy. All right, so that being said, we're going to go into some risk management for breast cancer in males and females, and we're also going to talk about a few other cancers. So specifically, we're going to talk about prostate cancer, and we'll talk a little bit about pancreatic cancer because that has such a high mortality. So let's get into it. Let's say that we have a female who is a carrier of BRCA1 or BRCA2, and they do not currently have cancer. Well, what are the current recommendations? So for an individual that's assigned female sex at birth, they should begin self-assessment and be taught how to do proper self-assessment and self-breast examinations beginning at the age of 18. Number 2 is clinical breast exams by an experienced physician or healthcare professional should be performed every 6 to 12 months beginning at age 25. Now, starting at 25 and specifically between the ages of 25 and 29, annual MRI breast examinations are recommended. Now, why an MRI and not a mammography? Well, in that third decade of life, so 20 to 30-year-olds, the breast tissue is very dense, and so traditional mammographic techniques may not pick up early cancers. And so the NCCN recommends that MRI is done for detection of early cancers. Now, what other risk reduction can be done for breast cancer? Well, a bilateral prophylactic mastectomy with or without reconstruction. Now, what other risk reduction strategy can be done for breast cancer? Well, a bilateral mastectomy with reconstruction or without reconstruction can be done for prevention of breast cancer. Now, there are 2 meta-analyses that have shown that prophylactic bilateral mastectomy reduces the risk of breast cancer. And one of these studies did show that risk-reducing surgery is significantly associated with reduced mortality. And I will put that study in the description below. The important thing to realize is that risk-reducing surgery, risk-reducing bilateral mastectomy, is a conversation between the patient and their doctor and their surgeon. And so is that a proper strategy? It's a proper strategy based on the individual, and that is incredibly important. Now, the other thing to talk about would be chemo prevention, and specifically that would be in selective estrogen receptor modulators like tamoxifen or raloxifene, which have been shown to decrease the incidence of invasive breast cancer. If a breast cancer develops in the setting of a BRCA1 mutation or a BRCA2 mutation, there is an increased risk of contralateral breast cancer as well, and that risk can be very high. So the main point I want to get across is in families that have a high risk of BRCA1 or BRCA2 mutations, a high risk of family history with breast cancer early on, we need proper risk assessment and an appropriate risk strategy moving forward, as there's not just the risk of invasive breast cancer in the one breast, but a high risk of contralateral breast cancer. Okay, let's go and look at males with breast cancer. What are some risk-reducing strategies for males who may be BRCA2 or BRCA1 carriers? Well, if we take a male who is a carrier of BRCA1 or BRCA2 and does not currently have cancer, then the risk-reducing strategy would be an annual mammogram. Well, when do we start mammograms in males that are carriers of BRCA1 or BRCA2? We would start mammograms at the age of 50 years old or 10 years younger than the earliest family member who developed breast cancer. Now, when we look at breast cancer and gynecomastia, though gynecomastia may be associated with breast cancer, it's not a risk factor for breast cancer. Okay, let's move on. Let's talk about risk assessment and prevention in ovarian cancer. So the current recommendations by the NCCN are for a risk-reducing bilateral salpingo oophorectomy between the ages of 35 and 40. Now, that will take out the ovaries and remove the fallopian tubes to decrease the risk of ovarian cancer or a fallopian tube cancer. What is another strategy? So oral contraceptives can be used to decrease the risk of ovarian cancer. And it's been demonstrated that oral contraceptives may reduce the risk of ovarian cancer by 45 to 50% in carriers of BRCA1 and up to 60% in carriers of BRCA2. Now, there may also be an increase in incidence of breast cancer with oral contraceptive use. So again, an important conversation to have with a specialist if yourself or a family member or a patient has a BRCA1 or BRCA2 mutation. So for breast cancer, we talked about surveillance starting very early so that we can detect early breast cancers. We also talked about risk-reducing surgery. For ovarian cancers, we talked about risk-reducing surgery or the use of oral contraceptives. And now let's look at prostate cancer in males. So we saw specifically for BRCA2 a significant increase in prostate cancer in males carrying that mutation. So what do we do about that? Well, males that have BRCA2, it hasn't been shown to have an increase in prostate cancer with BRCA1, but looking at BRCA2, they should undergo prostate cancer surveillance beginning at the age of 40. And finally, what is the risk management for pancreatic cancer? We talked about BRCA1 and 2 being associated with a lot of different cancers, but looking at pancreas specifically here to finish things off, there is not a good agreement in a specific pancreas imaging surveillance protocol. There are some studies that have been shown to do increased surveillance in those with a family history of early pancreatic cancer or in those families that have a P53 gene mutation to undergo early surveillance so that early cancers can be resected, but not specific surveillance in BRCA1 or BRCA2 mutations. So today we talked a lot about BRCA1 and BRCA2. We talked about what it is. We talked about what it does normally. So normally homologous recombination for double-stranded DNA breaks, DNA repair. When you get a mutation, that no longer works. We have an increased incidence of cancers. We talked about the founder effects in the bottleneck populations, like the Ashkenazi Jewish population, a risk of BRCA mutations as high as 1 in 40. Also, the Icelandic populations increased in African Americans and others. The other important thing is that BRCA mutations lead to the increased incidence of triple negative breast cancers. Well, what is a triple negative breast cancer? A triple negative breast cancer is a breast cancer that's estrogen receptor negative, progesterone receptor negative, and HER2 negative. Now, those cancers tend to be more aggressive. They tend to have a worse prognosis because there's reduced therapeutic options for treatment of that cancer. We talked not only about breast cancer, we talked about ovarian cancer, prostate cancer, and pancreatic cancer. We talked about some risk management strategies for each of those. I hope you enjoyed this today. If you haven't had a chance, I would check out the breast cancer video. That is the video that I most recently put together that takes a deep dive into breast cancer, what it is, talking about risk assessment, family history. I even take you through a calculator that you could use on yourself or, of course, your patients. I put a link to that in the description below in that video. So check out the breast cancer video. The other one, if you haven't checked out, is my wound healing series. That's not really associated with BRCA, but it's a fantastic series, and I think you could check that out right there. Okay, as always, I want you to stay safe, study hard, and I'll see you next time.